Hi, my name's Shelby, and I am a research coordinator at Arthritis Research Canada. Today, I'm joined by three of the patient partners collaborating on our study, Bonnie, Philippa, and Peter. And this presentation covers some of the ways patient partners and researchers have worked together on a project on COVID-19 and immunosuppression. I would like to first give an overview of our team. We have 4 patient partners who represent the rheumatology, cancer, and transplant patient communities. We have 1 physical therapy knowledge broker who helps teams to use the evidence of how to co-develop and share evidence. There are also 5 main researchers, including our principal investigator, Dr. Antonio Avina-Zubieta. These investigators have backgrounds in rheumatology, cancer, public health, and biostatistics. Finally, we currently have 3 research staff members, including myself. Next slide. Here's a timeline of our research project, highlighting some of the key events. The first grant for this project was funded in May 2020, and the following month, our 4 patient partners joined the team. Throughout June and July, the team worked on co-developing a survey to go out to the public, which is an important component of this study and will be discussed in detail later. In fall of 2020, we co-developed other necessary documents for this study, including a consent form and a letter inviting people to participate in the survey. In December 2020 and January 2021, we co-developed a whiteboard video to raise awareness about the study. This is another important component that will be discussed later. By February 2021, we had received our first set of administrative data for this project, including data on age, sex, health authority, and medical conditions of BC adults who tested positive or negative for COVID-19. Then, in the summer of 2021, we finished pilot testing our survey and mailed out the first invitations. Most recently, in January 2022, we began working on visual ways of displaying our study findings that can be shared with patient communities. This research project has 2 main aims, and the first is to assess the risk of contracting COVID-19 among people with compromised immune systems. The box on the right lists all of the patient groups that may have compromised immune systems that we studied, and it includes patients with rheumatic diseases, cancer, transplant, and chronic kidney disease and dialysis. The second aim of our study is to assess the risk of serious outcomes, including hospitalization, admission to the intensive care unit, and death, among people who test positive for COVID-19 and who also have a compromised immune system. In our study, one of the ways that we are gathering data is through a survey that is sent out to 2,000 BC adults who test positive for COVID-19, 2,000 BC adults who tested negative for COVID-19, and 2,000 BC adults who have not been tested. At this point in time, we've invited 1,500 people to participate in our survey. The survey has 45 questions, and participants choose if they'd prefer a paper copy mailed to them or an online copy emailed to them. The questions cover topics such as a participant's background, factors such as smoking and occupation, which may affect the chances of a person getting COVID-19, a person's history of vaccines other than the COVID-19 vaccine, which may act as a proxy for healthy behaviors in other parts of their life, and also beliefs about COVID-19. The survey process involves mailing a letter of invitation co-written by the team and a consent form to individuals' home addresses. If participants return the signed consent form, we send them the survey. If we don't receive the signed consent form within 3 weeks, we then mail them a reminder letter. 5 weeks after the initial invitation package, we make 2 phone calls to individuals who haven't returned their signed consent form or contacted us to say that they are not interested in participating. 2 phone calls are done to ensure that there were no issues with the address on file or lost or stolen mail. This presentation will address the ways the patient partners and researchers have worked together on this project, focusing on the survey documents and the whiteboard video. Now, patient partners will highlight these specific areas where they brought the patient perspective.
The first part of the research project, in which we as patient partners were invited to provide our feedback, was on the initial invitation letter that was being developed to be sent to the potential survey recipients. The first version of the letter, written by the researchers, we found to be heavy with medical and technical language that we felt would be difficult for the average person to understand and would not help with recruitment. After discussing the letter in a general meeting, we sent in our suggestions for changes. This was by direct editing of the initial version online or by email comments, depending on the comfort level with our computer skills. This slide illustrates one of the changes made by the patient partners, the title of the study itself written on the letter. The first version states, "Risk and outcomes of COVID-19 patients exposed to immunosuppressive and immunomodulatory agents in British Columbia, a population-based study." The simplified version states, "Invitation to participate in a research study about COVID-19 and how it may affect people who are immune compromised." This was one example of changing the language level to improve the readability. The official study title was added to the bottom of the invitation as an addendum. Next slide. Another change we made to this letter was the addition of a paragraph recognizing the impact that COVID-19 could be having on their lives. The research team recognizes the devastating impact COVID-19 may have had or is having on you and your loved ones. The patient partners who are part of the research team told us that is why this study is so important. The results could help us better learn how to minimize the effects of the virus on the lives of our loved ones and fellow citizens who are immune compromised. Part of the invitation included an incentive to increase participation in the survey, a common practice in projects like this. Initially, it stated, "To thank you for your time, those who return the survey will be entered into a draw to win one of 10 $100 cash prizes and one $1,000 grand prize." This generated a lot of discussion among the patient partners, including that the prize draw could be insensitive to families that have lost a member to COVID-19 and are still participating in the survey on their behalf, and that the reimbursement would only be accessible to a few persons rather than multiple people. And there were privacy concerns when recipients are contacted about their prize. And then financial incentives may not be appropriate, given the financial insecurity for many during a pandemic. Ultimately, we decided it would be more sensitive to donate money to a charity for each person who participates. As a result, the incentive was changed to the following: to recognize your meaningful donation of time to advance this important research, the project budget will allocate a donation of $2 for every person who participates in the study, up to a maximum of $2,000 to Food Banks BC to assist them in helping people through this difficult time.
The next key component that the patient partners provided input to was a whiteboard video. This was intended to raise awareness about the research project among the general population and to encourage people to participate in the survey. It is a short 2-minute video that features cartoon-style illustrations and voiceover that describes the key research questions and purpose of the survey. It can be viewed at the following link. The first draft of the video was developed by 3 members of the research team and then brought back to the larger project team for feedback and discussion. It went through several different versions, and during the editing process, the patient partners provided a number of suggestions that were primarily concerned with the speed and the clarity of the information being presented. In early versions of the video, the patient partners all flagged that they felt the voiceover information and images moved too quickly for them to make sense of the content. It was recommended that both the script and the number of images should be pared down to allow the viewer more time to absorb the content. It was also recommended that the transitions between the images should be slowed down. The patient partners felt that clarity could be improved in a number of places, such as where acronyms had been used in the voiceover or terms shortened for visual convenience. They recommended leaving images up longer, extending transitions, and using full terms. An example of this is when the ICU is mentioned in the voiceover. The full term intensive care unit was added to the images. Also, in the image indicating who we would be sharing the survey with, originally the text was smaller and presented in a shortened form. We recommended writing it out in full, COVID-19 positive test, COVID-19 negative test, or no COVID-19 test, and allowing more time for the viewer to linger on this frame and take in the information. In other places, the patient partners advised that simpler and more concrete images could be used to represent the information more clearly. One example of this was the image used to represent the idea of people with weakened immune systems. Originally, this was depicted using an umbrella as shield imagery. However, the patient partners felt that this was too abstract and caused the viewer to pause over it unnecessarily in the flow of the video. Eventually, the team arrived at an image of masked individuals facing off against viruses. The group felt this was clearer and more tangible in support of the ideas in the voiceover. To further promote clarity and ease for the viewer, the patient partners, with recommendations from the knowledge broker on the team, also advised some plain language changes, such as replacing community transmission with spread of the COVID-19 virus, replacing more susceptible to infections with more likely to get infections, and immunosuppression with weakened immune system, and replacing demographic factors with a person's background. There were also some interesting discussions and recommendations about how to close the video and the scope of its final summary statement. Recommendations to increase the demographic diversity represented in the images, adding more people of color and women, and also recommendations to make the video less situated in a specific moment in time and therefore more broadly usable. So the following changes were made to the voiceover, for example, where it said, British Columbians have worked hard to minimize community transmission. It was changed to British Columbians are working hard to limit the spread. And where it was with a second wave around the corner, it was changed to with the pandemic still ongoing.
Through this short presentation today, we have tried to highlight the dynamics that existed within our research team, specifically between patient partners and researchers. We present the following take-home messages for you that show the overall influence and impact that the patient partners brought to this project. First of all, the importance of using appropriate language in all documents that go out to the public. The patient partner initiated changes to documents and videos resulted in a more simplistic tone and communication style that a layperson could understand, thus enhancing the potential to engage a member of the general public. In the end, the survey document and the whiteboard video that were distributed publicly were more readable and more digestible to someone without any previous exposure to healthcare research and its inherent technical language. Another take-home message is the importance of having a knowledge. Given the high number of patient partners and the fact that these patient partners had lived experiences from very distinct medical backgrounds, the benefit of having an experienced knowledge broker allowed the patient partner team mission to be quickly established. The knowledge broker also proved to be the key go-between presenting patient partner input to the scientific team. The knowledge broker was important to incorporate as the research team had no previous experience working with patient partners. Thus, having the knowledge broker helped establish a comfortable setting to hold regular meetings where the patient partners had the ability to ask questions and speak freely. Overall, there was a sense of safety among patient partners in expressing oneself. There was never a fear of not being knowledgeable in a certain field. As a result of all this excellent environment, the best output from the meetings we found just came from easy and candid discussion between patient partners and research team members. While ultimately the goal of the research project is to provide statistical data for use in public health care, obtaining this underlying data depended on getting reader engagement. And the public-facing materials that we've been speaking about in this presentation required a communication style that enticed someone to complete the survey. The team of patient partners heavily influenced the critical outreach materials. Next slide, please. There was a number of organizations affiliated with this project. And these include the Michael Smith Foundation for Health Research, BC Support Unit, Population Data BC, Arthritis Research Canada, BC Cancer Agency, the University of British Columbia, and Simon Fraser University. If you want to learn more about this research project, the next slide will have links and QR codes. And we will also put these links in the Zoom chat space for your reference also. Thanks for watching our presentation.